think we keep meeting webinar to webinar. Right?
Yes, madam. Yes, madam.
I thought it's 7:01. Shall we start? Or?
Utilization, good evening. Good evening, Utilization.
Good evening, sir. Doctor, good evening.
Good evening, sir. Oh, you have joined.
Sir,
Okay.
good evening, sir. Good evening. Thank you, sir, for coming.
Thank you for joining.
Thank you, ma'am.
So,
Saravanan has gone off.
ma'am,
Ma'am, I'm here.
Okay.
ma'am, we'll start.
Aravind இருக்காப்ல.
Yes, sir. Yes.
Good evening.
Aravind திருநெல்வேலியில இருக்கீங்களா?
Sir?
அனிதா பேர் போட்டிருக்கு உங்களுக்கு.
இல்ல சார், அரவிந்த் மதுரைன்னு இருக்கு.
அப்படியா?
Sir, என் பேரு தான் இருக்கு சார்.
ஐயா.
எல்லாருக்குமே உங்க பேரு தான் இல்ல. I think
ஆமா, ஓகே. என்னோட பேனல்ல இருந்து நீங்க என்னோட இதுல இருந்து போனதுனால ஓகே ஓகே சார்.
அப்படிதான் இருக்கு.
I'll rename.
சரி, ஓகே. Sir, we'll start, sir.
Yeah.
Good evening. Good evening to one and all. I'm Dr. Anita Venugopal, Head of the Department, Corneal Services. On behalf of Aravind Hospital, Tirunelveli, I welcome you all to today's special webinar on eye banking in view of 38th National Eye Donation Fortnight. We, Aravind Hospital, Tirunelveli, have joined virtual hands with District Science Center, NCSM, Ministry of Culture, Government of India. They have been constantly engaged in popularizing science and technology among public schools and colleges. This time, they have agreed to join us for the noble act of spreading awareness on eye donation. We have with us the Tirunelveli District Science Center Officer, Mr. S.M. Kumar with us. Thank you, sir, for joining us. We have started our Rotary Aravind Eye Bank in the year 2004, during which we received only 22 eyes in a year. Slowly, by spreading public awareness and joining hands with Rotary and Lions International organizations, we could get introduced to people who were voluntarily willing to work with us in eliminating corneal blindness. Till last year, we have retrieved 6,863 eyes through our eye bank. We have with us our District Governor, Rotary Club of West Tirunelveli, Rotarian R. Muthaya Pillai sir with us. Thank you, sir. They have been constant support to us in this mission. So we have two key speakers, I should say two heroes of this session. Esteemed speakers, Dr. Radhika Natarajan ma'am, the Deputy Director and Head of the Department Corneal Services, Shankar Nethralaya, Chennai, and Mr. D. Saravanan sir, Eye Bank Manager, Aravind Hospital, Madurai, are with us for sharing their extensive experiences in eye banking. They are not just experts, but they are the true enthusiasts and driving force behind it. So in the panel,
it's our great pleasure to join hands once again with Aravind Eye Hospital.
Hello, sir.
Very
good evening, sir. Good evening, sir. How are you?
Very fine, sir. Very fine. Thank you for seeing you once again. You're too busy. At least you are meeting online. So it's a great pleasure to join hands with Aravind Eye Hospital once again. Actually, we have been doing a lot of programs on physical as well as online programs. Even during our Corona period also, we had a lot of webinars, including black fungus and all that. And we had a lot of competitions, contests, and seminars, including free eye screening camps and awareness programs with the exhibition as well as display materials, courtesy Aravind Eye Hospital. I hope this program will reach out to more people, and in future, let us plan it still more in advance so that these publicity materials could be easily disseminated to a large group of audience, which will really touch, and it will be much more helpful if we can reach the younger audience, the children, so that our purpose of serving the society will be served better. Thanks a lot. Have a great day to all the great speakers, and thank you. Have a great day.
Thank you, sir. So back to the webinar. In the panel, we have Dr. R.K. sir, the advisor, Aravind Hospital, Tirunelveli. Under his strategic leadership has been an initiative for us to start our iBank. Under his mentorship, we not only gain practical knowledge and insights in ophthalmology, but sir has helped us in professional growth, build confidence, and manage work-life balance. Next, we have our Chief Medical Officer, Dr. Meenakshi ma'am, Director, Rotary Aravind iBank, with more than 25 years of experience in the field of iBanking and corneal transplantation. Madam has been a constant guide to all of us and continues to mentor next generation of iBanking professionals. Next, we have our Dr. Josephine Christie, Head of the Department Corneal Services, Aravind Hospital, Pondicherry. She is an young, enthusiastic person who would never say no to me for scientific papers and publications. She has many roles to play. Past secretary of Pondicherry Ophthalmologic Society, and she is the iBank in charge and MLP in charge in Pondicherry Aravind Hospital and the ethical committee secretary. I consider Christy as my true comrade in terms of our views and thoughts. Welcome, Christy. I'm truly honored to welcome all the speakers, panelists, Rotary and Lions Club and District Science Centers for the webinar. Without further ado, I warmly welcome Dr. Radhika Natarajan ma'am to speak on evolution of iBanking and current Indian scenario. Ma'am, your passion for teaching and guiding postgraduates and young ophthalmologists is truly infectious. And as a clinician, researcher, and mentor for more than 25 years, a special interest around corneal infections and inflammations. Thank you, ma'am, for joining us. It's all yours, ma'am.
Thank you so much, Dr. Anita. I find your enthusiasm to be infectious in most clinical as well as academic domains. And thanks to Dr. Meenakshi, Dr. Christie, Dr. Ramakrishnan, and Aravind Eye Hospital for having me on this platform. To put you in a listening mood for this evening, let me start with a very short story. On a hot afternoon, two friends were walking along the beach. They saw an old man throwing stones into the sea. They were a little curious, so the boys went close by, and they saw that the man was not throwing stones. A lot of starfish had washed onto the beach, and one by one, patiently, this elderly man was restoring them back to the sea. So one of the boys stopped and asked him, "Grandpa, what you're doing is excellent, wonderful. But there are so many of them. Do you think it's really worth it? Will you be able to finish doing this?" The old man stopped, looked at the friends and smiled. He showed to the area where he had cleared the creatures on the beach and said, "For all these creatures, it has been worth it. And for this little guy in my hand, it is going to be worth it." Dear friends, that is the spirit of service. Not one person, it is possible to do everything. But every little bit that every person does goes into the whole pool to achieve that kind of service. And iBanking is no exception to this rule. I am Radhika from Shankar Netralaya. I do not have a visual presentation with me because I believe that iBanking is a passion. It is not a PowerPoint. iBanking is not an Excel sheet from which you can read out statistics like there are 7 million corneal blind patients in India, even though that in fact is a truth. 1 million of these people are bilaterally blind in our country. And the sad fact is 20,000 get added to the bandwagon every year. And more than half of these have treatable or preventable causes of corneal blindness. Let us see an example. Suppose we had a car in which the windshield was shattered and the engine is working. Would we dispose it of? No. So this is akin to the fact when patients have an intact retina and optic nerve, but they are walking around blind because of corneal reasons. If such is our careful approach to an automobile, then why on earth should anybody be more careless about precious human vision? Let us see where we are in our country as far as iBanking is concerned. India is home to about 240 iBanks. And if you think that this is a very large number, the most staggering fact is that there are 740 affiliates which can function along with these parent eye banks, meaning there are 740 institutions that can benefit from the guidance of an eye bank and also function alongside. So it is a world-known fact that India is home to one of the largest number of eye banks in the world. And the most important form of eye donation that happens in our country is voluntary eye donation. It has been there for a very long time. It is a very successful program which kind of runs on itself. It is self-supporting and it is propagated by word of mouth. VED, as we call it, forms the backbone of eye banking across the world and as also in our country. As opposed to that, we have the younger hospital cornea retrieval program. This is a program which my successor will probably speak about, which reaps the organ, the cornea, from hospital deaths. This is a younger program. It has to have a bit of more infrastructure. It needs principles like grief counseling to be in place. And both VED and HCRP have their own advantages and disadvantages. VED is a program which runs on its own, but the life expectancy in our country is becoming more and more. Therefore, the tissues that we receive sometimes are a little on the older side, and sometimes, not always, the quality of tissue that we want is not possible to achieve by VED alone. Hospital cornea retrieval program, on the other hand, gives us younger tissues. So we are able to, retrieve from deaths occurring in hospitals with younger patients. But the problem is that hospital patients come with their own share of problems like exposure, infection in the eye, sepsis in the body, which can, preclude utilization of the eye, and so on. Also, the method of retrieval is also twofold in our country. On one hand, we have whole globe extraction, and on the other hand, we have in situ corneoscleral rim removal. Again, here we have an advantage and disadvantage in either. Whole globe extraction has to be done by trained professionals, either ophthalmic postgraduates or such. And whole globe extraction, though, gives us the valuable resource of sclera. On the other hand, in situ extraction, which is commonly practiced in hospital environment, can be performed by trained technicians. But in situ extraction, it is not possible for us to get sclera. And in our country, at this point in time, we have both types of extraction happening hand in hand through various eye banks. Also, the method of storing the donor tissue is slightly different in our country compared to the West. We use mostly MK medium and a bit of intermediate storage like Optisol or Cornisol. Whereas in the US, it is more of Optisol, and in Europe, it is largely eye banks use only organ culture medium. This is because in our country, maximum donated tissue is used for emergency or semi-emergency purposes. Therapeutic penetrating keratoplasty forms the mainstay still among keratoplasty in our country. On the other hand, in the Western world, infection is rare and there are longer waiting lists. They have more elective surgeries which are done for corneal decompensations, and therefore they need media which work out on a long-term basis. And all the more in the Europe, where the waiting lists are extensively long, the more expensive organ culture medium is employed. So this is the state that we are now at this point in time in comparison with the rest of the world. So what do we do to take this established steps of eye banking a little further? Before we want to do more, we need to introspect and see whether we are doing what we are having adequately and whether we are utilizing what we already have adequately. There is no point in saying that I want more and more unless we are able to use what we have properly. So do we need more eye banks? No, we already said in the beginning of the talk that India houses one of the largest number of eye banks. So what is more important as a first step to run the program better is better tissue utilization. So tissue utilization starts with a few small steps first. For example, we know that tissue has to be screened before utilization. and tissue that needs to be discarded for medical reason, unfortunately, cannot be used because it can be harmful to the patient and sometimes to the surgeon as well. But how many of us really know that there are small steps also along the way which can cause or which can avoid a delay? For example, if we process a sample which has been kept waiting for a little long time, that can turn out to be HCV positive. So that causes unnecessary wastage of that particular tissue. Also, we say in a standard fashion that tissue needs to be retrieved and utilized over 6 to 8 hours time. But if the environment is a little cooler, for example, a mortuary retrieval, then we may be able to utilize that kind of a tissue or retrieve that kind of a tissue even up to 12 hours, and it may be still usable for the patient care. Also, another baby step would be to match the resource. So we need to match the place and time where the donation is available to the eye bank. So on one hand, we have a lot of eye banks. On one hand, we have poverty among plenty where eye donations can happen in rural or semi-urban areas where eye banks may not be there. And resource matching may be an important way to increase the tissue utilization. How can we do that? Imagine this: if we had an eye banking app where we have details about eye donation in an engaging form to the public, which is given with a little bit of legal limitation, then that can be a resource to link up available eye donation with available eye banks. If Swiggy and Zomato can identify people who are hungry, and link them up with a restaurant or a shop which provides food, and integrate the two using service people, then this should be easily possible. So an eye banking app may be a small thought in this eye banking fortnight as a means of increasing tissue utilization and as a means of linking up an eye bank with a potential resource where a donation can happen. Also, we know that this is the day and age of compartment corneal surgery. Means one single donor cornea, at least in theory, a large extent to practice also, can be utilized for anterior lamella, posterior lamella, keratoplasty. You can use the limbal tissue, you can use the sclera. So technically it is possible to use one cornea for a lot of surgeries and for multiple patients. It may not be possible to do this all the time, but the point that I'm trying to make is another way of utilizing tissue or increasing tissue utilization is when we train our proteges, our training corneal surgeons, they must be aware of it so that even if they're not able to do it every single time, they have this thought process that one tissue can be made use of for multiple surgeries. And speaking of training surgeons, it should be inculcated in them that tissue can never and should not ever be wasted. Unless, of course, it is being discarded entirely for medical reason because of abnormal blood tests or contagious diseases. And if the tissue is below par for optical utilization, it can be used for therapeutic purposes. And to take it one level further, if it is even not possible to use it like that, it can be used as a resource for teaching and training, for suturing practice and for trephination, etc. And one level further, once it has been used for this, there is a lot of corneal research which is happening in corneal tensile strength and so on and so forth. And the tissue which is utilized for the wet lab can again be passed over to our laboratory colleagues who can then employ it for those research purposes. So every bit of donation, unless it is absolutely not possible to be used, should be utilized, because this is not only a non-renewable resource, it is a piece of sanctity. It is being donated by somebody who was living at one point in time. Also, speaking of trainee surgeons, as a collateral, eye banks and associated institutes should invest some amount of time and energy in training these people, the new trainee surgeons, in procedures like holistic keratoplasty. So I'm saying this because the Western world, the more common diseases like we already saw involved anterior lamellar and posterior lamellar keratoplasties, because their keratoconus and corneal decompensation seem to form the mainstay of patients. Whereas Dr. Anita and the others on the panel will definitely agree with me that we have a large share of corneal infections which need acute therapeutic keratoplasty and corneal scars in the form of adherent leucoma, which still require full thickness keratoplasty as an elective procedure. we have our MELS, our malnutrition, our infection, which still call for a lot of full thickness keratoplasty. So there has to be focus, which has to be drawn a little bit from Western type of keratoplasty to these keratoplasties in which the trainee surgeons should be trained. That way, if they have the technique integrated in them, then the tissue utilization can also be a little better. Also, on one hand, when we are doing this, eye banks have to squirrel away a little of their resources into research which involves newer alternatives. For example, on bioengineered cornea, on alternatives like app-based methods, which will allow the corneal blind patient to see using computer vision rather than corneal transplant. If you think what I'm talking is a little far-fetched and sounds like science fiction, I wish to recall a small quote where the chief of IBM, IBM is the company which manufactured the first computer. That computer was mammoth. It was housed in a large room with a lot of electrical connections, very expensive to build. So the chief of IBM famously remarked at that time that, we have spent so much of time and money on this unnecessarily. Maybe there will be a world demand for 5 more of this equipment. And he can't be more wrong. Because today we have a lot of devices on our pockets, on our desk, everything which runs on a computer. So what sounds as far-fetched or science fiction at this point in time may play out to be standard of care in the future. So eye banks should not work like horse with blinkers. They can, on one hand, train the surgeons to be frugal with the tissue, train them in full thickness keratoplasty. At the same time, invest some resources on futuristic techniques which will reduce the demand for donor cornea. And speaking of awareness, which is the theme of this fortnight now, awareness, I believe, is not something which we speak about just during the fortnight or we just address when it catches our fancy. Awareness is something that we do in our day-to-day practice. How? There is always a small group of people that we can manage to influence, our peers, our colleagues, sometimes our seniors also, people that we work with. So constantly, if we keep repeating the importance, then even a little bit percolates, then it adds a value to the movement. If you think back, in our growing years, our parents, our elders would have repeatedly told us some things, which we may not even lent a ear at that time. When that situation comes in our life, that advice comes back to our mind. Like that, even if one person among 10 people whom we have spoken to gets influenced, it has to be done on a daily basis, is what I'm trying to say, because it is very nice to have programs like this. Why? Because we keep reminding ourselves of the job at hand. But after that, the awareness is something which has to continue on a daily basis rather than just during the fortnight. And as far as public instruction is concerned, we need to be very specific. At least in our country, there are a lot of, it's a mix of literate, semi-literate and illiterate population that we address during eye donation talks. So we need to be very specific. Otherwise, they will sit in a lecture, they will get motivated, but once the situation comes, they don't know what to do. Right? So it is like somebody teaches how to, program an app with the computer. We are not basically coding people. So unless we do it on a daily basis, we are not going to remember when the time comes. So the public has to be given specific instructions. The first is regarding the pledge. A pledge is a very nice thing. A pledge is a wonderful form of motivation, because if one person pledges, then their next of kin, people in their office, everybody gets to know. So pledge is a wonderful method of propaganda. But the public also needs to know that a pledge is not compulsory for donation. People should not think that pledge does not happen, so donation cannot happen. To extend one step further, the public should also know that a person need not have willed his or her eye for donation. Many people seem to think that my father has not willed his eye, my mother has not told me about it. They need to be made aware that the next of kin has got all the legal rights to call the eye bank to take the donation. And a third point of public awareness should also include removal of all the stigmata associated with eye donation, because people will think that it disfigures the body, it delays the funeral, person will be born without eye in the next birth. So these kind of stigmata need to be removed during public awareness. So if these are all packaged and dispersed to socially conscious youngsters, they may be able to spread it in social media. And that also helps to run this program in a bigger and better fashion. I already mentioned that our country does not require the expensive long-term preservation methods. But if one thing that COVID has taught us is not to waste tissue. So over and above all the utilization, if we are anyway going to discard eyes, we may as well preserve them in glycerol. Today, I see a lot of papers coming up about bioengineered corneal stroma. You may not be in the same page as me, but I believe that before building bioengineered corneal stroma, we should fortify the existing corneal stromas in glycerol. It is the endothelial repopulation that we should bioengineer, because on one hand, we keep throwing out corneas, and on the other hand, we build, a collagen material for bioengineered corneas. It doesn't really make sense to me, because these glycerol preserved acellular tissue may not be able to function as optical grafts, but they will definitely come in handy during emergency circumstances for therapeutic and tectonic purposes. Also, in our country, I have already mentioned that there is a disparity between the location of the eye banks and the areas where the donation happens. So along with app building, we can also develop technician training programs. If we are not able to source qualified medical professional to go and retrieve the eyes in semi-urban areas, with the help of an in-house doctor monitoring, the trained technician can be the resource who can go and bring the eyes back to the eye bank, where it can then be distributed to an area where it is required. That way, the demand and the supply can be bridged by increasing the technical training. And how can we do this? How do we know, which resources where and how to coordinate? So that is when we are aware of a need for having a centralized registry. Imagine if we had a central place. It could be virtual or it could be physical, where every bit of data is documented. Now, all the documented data which exists presently is to do with the licensing and the renewal and running of the eye banks. But if we also incorporate registry, which will tell us about the donations happening, about the eye banks running, about the tissue utilization, about the training programs happening, about technicians available, much like the way that we collate, budget or income tax, then it can become a formidable resource based on which for subsequent years we can decide, where the lacunae are. Quite often we'll be surprised to find that, what we have to newly purchase or newly do is less. Many times it will be a question of taking the surplus and filling it in the deficient area. So all nicely said, but then, who will do it and how to support the incidental cost for all this? I'm talking about eye banks channelizing a little bit of their resources here and there, but any of us who's worked in an eye bank know how much of a shoestring budget that we have to deal with. So I think we may have a solution there also, because we have a lot of manufacturing companies that deal with ophthalmic equipment and medication, whom we rely on and whom we make purchases on a daily basis. So many of these are multinational companies as well. So if there is a law or a legislation, if the government would step in and tell that, each of these companies who benefit because of these purchases should handhold an eye bank for some activities, depending on the size of the company and the profit that they make, some or more activities of an eye bank, say for a year, as a legislation for them to continue to, make these supplies, I think it will serve the twin purpose of giving a shot in the arm for these eye banks to function in the manner that I said now. And it will also, involve completing the corporate social responsibilities, which anyway these companies have to be fulfilling. So it is a win-win situation where the eye bank also benefits and the company can also show the completion of their responsibility. So the point that I'm trying to make is that I'm sure Dr. Anita, Dr. Christy, and Dr. Meenakshi, Dr. Ramakrishnan will agree with me that eye donation is probably the simplest of donations. Why? Because we don't have to have a living donor. We don't have to have a brain dead patient. We don't need trained medical people all the time to go and retrieve the eye. We don't have to have the police clear the green corridor for the organ to be transplanted, transported, and we don't have to have the patient ready waiting for the transplant. So it is among the easiest of donations to happen. All the above are applicable for all the other transplants. If that is the case, it is really pathetic if the eyes are going to be burned or buried after death. And how can we avoid this? We, the corneal surgeons, should think of not only new strategies, but how to integrate what we do in our daily practice, as what I told before, to make this bigger and better. We, as the handlers of this exquisite piece of tissue, could act as the best brand ambassadors to keep this program running on its wheels and also to take it forward. Thank you so very much.
Thank you, ma'am. Thank you, ma'am. It was a very nice, excellent talk and informative, and we all enjoyed, ma'am. Sure. We will
Thank you,
have we will have our discussion at the end of the second talk, ma'am. The next speaker. I will share this. Next speaker is Mr. D. Sharavanan, iBank Manager, Aravind Hospital, Madurai. He has been working in Aravind Hospital, Madurai iBank for past 12 years. After his master's in social work, he has done his Site Life Fellowship in US. His special interest is on the quality, innovation, and project management. He has played a major role in the growth of Aravind integrated iBank services. So he would be speaking on the hospital corneal retrieval program, our experience.
So good evening, everyone. I am Saravanan, working as iBank manager at Aravind Eye Care System. And I have to say thanks to ma'am for given a larger perspective of eye banking and eye donations. So here I am going to talk about exclusively hospital corneal retrieval program based on our experience. Next, ma'am.
Sir?
And can I operate myself or? Yes. So usually in the eye banking sector, we have two kind of strategies for mobilizing the eyeballs. One is called community corneal retrieval program. So here we are mainly focused on the community. So we are creating awareness among the community, and we are bringing the volunteers through our community programs. So we are providing a lot of awareness and sensitization program to our volunteers, and they are acting as a bridge between the disease family members and iBank. Nearly we are getting 65% of the tissues through our community corneal retrieval programs. So next we have a hospital corneal retrieval program. This is the second strategy of mobilizing eyeballs in the eye banking, and it was initiated in 1990 in India. And Government of India and iBank Association of India highly insisted to do this program. So next. So here why we started as Aravind Eye Care System, why we started this hospital corneal retrieval program. Basically, one is, as you're well aware of it, ma'am communicated everything very clearly. There is a huge demand and supply of cornea processed in India. As per the prevalence rate, almost 10 lakh population, they are waiting for corneal surgery. The supply of India in every year is only we are doing 25 surgeries in a year. So considering the demand and supply differences, as Aravind Eye Care System, we are taking this as a challenge and are working for providing vision to the corneal blind. And basically as a resource, right? We have needed a resource to increase the supply. So the death is a resources for all the eye bankers to collect the tissue to increase the supply. So here in the hospitals, we found a lot of potential death at the hospitals, and definitely we understand to bridge the gap of demand and supply. So we are keep on working with various people for bridging the demand and supply differences of India. Next. So here we have divided the hospitals into three categories based on the mortality rate. So high, medium, and low mortality hospitals. For the high and medium mortality hospitals, we are implementing the projects. And for the low mortality hospitals, we are working as a voluntary model based on the voluntary models. So for the high and medium mortality hospitals, we are implementing the hospital cornea retrieval program. Next. So we did a lot of groundworks to the high and medium mortality hospitals. So usually we got an approval from higher officials from the government departments. So we have explained the need and importance to the higher officials from the government at the government hospitals as well as from the donor hospitals. And we have submitted a lot of required documents to them then and there. So whenever they need any documents related to the implementation of hospital cornea retrieval program, immediately we have immediately submitted all the required documents, and we are clearing all the doubts whenever they need. So we have also continuously followed them to sign the MOU. This is foremost important. I observed in India, most of them initiate the conversation with the hospital, but they are not keep on following them for signing the MOU. But this is foremost important for continuously following to sign up the MOU. Next. So once you sign the MOU, what we are doing is we have recruited the trained counselor come technician at the mortuary of the donor hospitals. This is foremost important from the selection to train. So we are providing proper training and practical session to the eye donation counselor come technicians, and we are also having a periodical competency review to all the technical persons. It's really help us all the individual technical persons to improve their capability day by day. So we have all, as a first step, we have organized our inauguration program at the donor hospitals to get to know about the HCRP program. It's very easy for us to involve all the players, stakeholders in the particular hospitals. So once we finish up all this groundwork, we have a set of implementation process at the donor hospitals. Initially, we have a orientation program at all the levels. So usually in the donor hospital, we have a 3-tier system of communication. So the higher level, the medium level, and the tertiary level of communication. So we are focused on all the stakeholders in the hospital in a different meetings. So we have organizing different orientation programs to them. We have to educate them on the hospital cornea retrieval program, importance of eye donation, and creating the death notification from the donor, from the hospital staff to eye donation council. We have also displayed the information board at the donor hospitals. It really helps us, the patients, they get to know about the eye donation, as well as whenever they come across any death at the hospital, immediately they have to contact the eye donation counselor very easily through this information flow. So the creating death notification, it's also foremost important because all the deaths should be notified to the eye donation counselor. Then only he or she has to approach the family members and make sure that all the eye donation process completed or not. So the eye donation counselor usually concentrating on the deaths that happen in the hospital, and we are having a death potential analysis. We are usually doing at all the hospitals. So usually we are focusing on the ICU, IMCU, IRMCU, trauma wards, and the eye donation counselor usually making a sensitive request to the deceased family members. If they're given a consent, then the eye donation counselor will do all the process and retrieve the quick, convenient enucleation at the donor hospital itself. Next one. So the advantages, as Madam said, one is the access to younger, healthier donor tissues from the hospitals. Then the higher utilization rate. So usually, the community cornea retrieval program, the utilization rate is 30 to 40%. If you take HCRP, the utilization rate is very higher. It's 70 to 80%. This is a very advantage to us. We can do lot of surgery to the good quality tissues. And the availability of donor medical history is very easy for us, and it allows us to better tissue evaluations too. And we reduce the death to enucleation time. So these are the advantages, and we can get a lot of good quality tissues from the hospital cornea retrieval program. Next one. So currently we have been implementing this hospital cornea retrieval program in 13 major medical college hospitals in Tamil Nadu. So we have followed, as I communicated, all the implementation process. we are implementing the same process at all these hospitals, all the donor hospitals. Next. So as I said, these are above topics, above content. So it's very useful for the high and medium hospital donor hospitals. For the low mortality hospitals, we are creating awareness among the hospitals, and we are bringing the volunteer from the staff group of the particular hospitals. So we are creating a death notification. The particular volunteer should be, whenever they come across any death, they immediately communicate the death notification to our IBAN. So we are offering a telecounseling to the deceased family members. If it's very close to IBAN, then we are dealing directly to the deceased family members. So it's we have also quickly addressed all the enucleation calls without delay. Somehow we are ensuring 100% coverage to high, medium, and low mortality hospitals. Next. So this slide, no, clearly, I mean, show the performance from the inception. So we have started 2012, the HCRP program we have started at Madurai Rajaji Hospital. And initially we have received 76 tissues within 4 months of the HCRP implementation. Then we have been gradually extending these projects to Dindikal, Chennai, Sivagangai. So last our 10 years experience, the last year collection, almost we have crossed 1,300 tissues in a year. So if you are properly implementing hospital corneal retrieval program, we can able to get lot of good quality tissues from the hospitals. The next, so we have been continuously working with, next month. So we have been continuously working with various government and private hospitals and primary health centers and urban health posts. And we have also working with nearly 40 to 50 private hospitals for mobilizing corneal tissues. Next. So after removal of eyes, we have a set of evaluation. So after completing the all evaluation, as Madam said, so the quality tissues we are distributing for performing corneal surgeries. And if the tissue is not suitable for surgery, we are using it, positively using it for research and training. Somehow we are not wasting single tissues for any reasons. So next. So the impact of this hospital corneal retrieval program, we are continuously increasing the number of eye donation. So we are providing vision to corneal blind people. That is our vision. And we have reduced the corneal blindness, not only Madurai, for not only Tamil Nadu. So we are addressing all the government Indian needs. Next. Next one. So as a whole, we call as Aravind Integrated Eye Bank Services. And we have established at 1998 with the vision of providing solution to corneal blindness. So we have properly procured, process, and distribute the quality corneas to transplant. And as I said, if the tissue is not suitable for surgery, then we are effectively using it for research and training. So we have 5 eye banks in Madurai, Coimbatore, Tirunelveli, Pondicherry, and Chennai. So next. So we have collected almost 5,000 to 6,000 corneas in a year. And we have collected nearly 87,000 corneas from the inceptions. So as Madam suggested, especially on the eye banking app. So we have 4 years back, we have submitted the professional eye banking app on behalf of Aravind Eye Care System. It was discussed in various forums of eye banking sectors in India. So the government should, now we have submitted this professional eye banking of concept, to Government of India. Maybe in May, within a year, they may consider this as an important one, and they will take it further for better integrated of all the service related to eye banking. Next one. So thank you so much for your time. If you have any specific questions, let me. I will try to answer your questions. Thank you so much for the opportunity.
Thank you, sir. Thank you so much. it was surprising for us also to know the numbers of corneas which we have received through HCRP. That is an immense number, and also 13 hospitals we have signed MOU. That is a great achievement, sir. Thank you. Ma'am, to Radhika ma'am, I have a question. Like, what are the, like you said, ma'am, like about the better tissue utilization and matching the resources, for low and to the urban area or the rural area. So all those is little, it is difficult. But apart from this, so what is a major challenge for an eye bank in India? And because why I'm asking is many eye banks are just existing in numbers. I heard like in some eye bank meeting, and they are non-functional. So what we have to do, like as we are cornea specialists, like what we have, and eye bank professionals, like what we have to do from our side, and is there any role for the government to do this? Because DBCS is doing a great job actually. They are giving us, encouraging us and giving us funds, everything for collection of corneas. But what else they have to do? You said that that app is a very good idea, ma'am. Whether we can propose this to the government, how to take it to them, all those like.
Yeah, Dr. Anita. So basically, like you rightly pointed out, and I said in my talk also, it's a kind of a poverty amongst plenty. Do we need more eye banks? Definitely not, because we know that the ones which are available are not being utilized to their maximum capacity. Also, we have satellite affiliate centers for them also. So even those, are not functioning to the full capacity. In my mind, I'm not somebody who, talks in terms of charters and consortiums and big planning and all that. When I think of improvement of something, I think of integrating or enhancing what we do on a daily basis, because that is what we do the best. Suppose it is running in a particular way, what is it that we can do to add or subtract and make it a little better? In that respect, if you see, definitely the first step is, to increase the technical training. So if we can make technical training a little more lucrative and, recruit more number of technicians. So if the eye banks cannot, come to the eye donation, then the technicians can form a bridge where, the both can meet halfway. Because now we know with the HCRP and the in situ corneoscleral button excision that it is not 100% required for trained medical professional to be in the field. So technician training and increasing the eye donations by employing technicians is one method where we can utilize the existing eye bank. The second is by imposing some compulsory auditing. In the sense, like I said, all the bureaucracy or all the formalities which are involved with eye banking seem to do with the functioning and the licensing and the renewal and all those things. There is very little focus that is attributed to the output of an eye bank. For example, it's not possible to increase number of deaths or, increase tissue retrieval artificially. But then there should be some ratio which should be compulsory, in the sense that if in medical colleges or even that particular population, X number of deaths are happening, then the eye bank should be able to show at least a fraction of that as retrieval. Some kind of a audit should be there, which should be imposed for the running of the eye bank. Otherwise, an eye bank which is sitting idly and collecting 10 eyes in a year, does not suffer any penalty as compared to eye banks which are fully functional in your institution and in mine. It is, of course, easy to say, but difficult to implement. Like it is not, a computer-based activity that we can say that you should discharge 10 units today before you go home. It's not possible to tell that. But some, tangential method should be arrived at so that the eye bank can, show in terms of numbers how it functions for it to continue its license. So some form of auditing, some increase in the technician training can help to increase the productivity of the existing eye banks. Otherwise, whether they collect 10 eyes or 100 eyes, if they are going to be, continuing with their activity, unless they themselves are motivated, there is no way forward at all. Lastly, the idea of an app has been with me ever since the pandemic, because in the pandemic, we are so used to relying on online shopping and OTT platforms that if there is a resource and a customer, which can be linked by a computer software and linking service providers. So that is what these platforms do. So here we have the resource, which is the willing donation, and here we have the customer, which is the surgeon or the patient, and the linking service will be the iBank. So why can't we integrate all three in an app? Of course, it's not as simple as any other OTT, because legal legislation has to be there, and so that people do not misuse it for any purpose. The same app can also be titrated to contain basic public information, because youngsters these days are more comfortable with information that can be scrolled rather than that can be heard. And if a youngster knows about it, the whole house knows. So the myths about iBanking, what is the importance of a pledge? What is the importance of kin being the source of the donation? If these small bits of information are there in the app, then definitely it will be a formidable resource to enhance this program. If some institutions can get together, iBanks of some institutions can get together and formulate this and get the government approval, then it may not yield result in one day. When online shopping started, Amazon was a bookstore, right? So these are things which will take time to pan out, and it is well worth investing our interest and energy into all of these things.
Thank you, ma'am. Ma'am, your inputs.
Thank you, Dr. Radhika ma'am. You are so passionate about this thing, and what you said about this app also, it's very good idea that we can do it. What about this? What do you think about your opinion about HCRP, Hospital Corneal Retrieval Program in Shankar Nethralaya? How is it? Is it very active program or?
So it is a definite active program. Like we both mentioned, me and your iBank manager, like we mentioned, it is a source of, it is a younger program, as you already know. It's been there only for the past few decades as compared to the voluntary eye donation, which has been there for a much longer time. So it took its time to pick up, and it picked up very well. And again, there, the peer influence is definitely there, in the sense that when one medical college knows that the other one is doing, then it becomes easier for us to influence or convince another institution to do it. But unfortunately, during the pandemic, it took a very big backseat. So, and now I should say 1.5 to 2 years down the line, it's back on its feet, and both should happen together. One cannot substitute the other, because the VED happens because of a social conscience and a moral conscience. That is the biggest driver of the iBanking program. So VED should also definitely be there. And HCRP is a source of younger tissue. And as pointed out in the earlier talk, we know the medical background, and it is very easy for one professional to convince another. So HCRP also should go in tandem. So I think we are also doing a good job. I can't point out the numbers over here. My iBank manager may be able to do that. But post-pandemic, we've made a remarkable recovery in terms of improving the HCRP and increasing the number of tie-ups as well.
Christy, I have a question to you. Handling myths, like I feel like in our community, the myths that are existing in the community against eye donation after death, that is still there, I feel. So what do you think that you can do to remove that in the community?
Okay, so the common, and first of all, ma'am, thank you for the very nice introduction. I did not get time to talk about it. And we had a very, very excellent talk by Dr. Radhika ma'am and Aravind sir, and thank you for arranging this. Yes, as you mentioned, like myths are definitely there, but the present generation is far better than the previous one. So they come forward to play, they ask doubts, unlike the previous generation. So we are looking forward to a very hopeful future generation, because they are going to be the next of kin for the next generation. So we are more focusing on the 30 to 40 years and 50 years, and we are going to factories and places where this population is more, because the generation is going to decide in the near future, not the college going or the students. So we are focusing on them, and after a lot of awareness programs, I feel the myths are coming down. People are willing to donate. They're ready to understand as well. I had a few more questions, ma'am. One of the major problems that we face here in our iBank is that we largely depend on voluntary eye donation, and so most often the time of death that the patient tells, and by the time we reach, so it might not be exactly 6 or 8 hours, but then I feel that even if it is 8 to 10 hours, the corneal quality is good. But rather the difficulty that we face is not able to take blood sample, or if at all they take a blood sample, it is lysed and is completely absent. So when we have a nice tissue at hand, we have the eyeball at hand, but still we are dependent on the serology, and like if you see, like if you're collecting 60 eyeballs in a year, or at least like say in a month, almost 10% goes for lack of serology or lysed blood. So is there any alternative for that? So that is number one question, ma'am.
So that unfortunately is a definite problem, because we can't, like you rightly said, not only the tissue goes waste, but sometimes the tissue gets utilized in a delayed manner also because of the blood processing and the delay in the report. For that, again, the people who are collecting, if they have regular training sessions with the phlebotomists, who actually draw and process the blood sample in living human beings, then they may have a better idea of how to do it. For example, we have finished our ICU postings long back. So suddenly, if you have to cannulate a vein, in theory, you know to do it. In practice also, you know to do it. But when you're doing it, all of a sudden, you may or may not get it correct. So the people who retrieve the blood at the site are also on the same boat. They do it once in a while, and they do it based on textual training rather than, actual day-to-day knowledge. So if we can link up revision sessions of, either the medical professional or the eye-banking technicians who go for the retrieval on how to take the blood sample and how to actually preserve it properly till the lab gets hold of it, then we may have fewer errors and, lesser samples being discarded, and therefore tissues being discarded. That is one point that came to my mind.
Thank you, ma'am. And also a question to Aravind sir, like is it a formal training program for technicians and leave counselors? Is there a proper training protocol, a certificate program or something like that available in India so that we can refer people? Because I see a lot of hospitals which are asking for technician training. So is there any availability? Can you guide us on that?
Yes, ma'am. Sure, ma'am. Actually, we have a certification program to the persons who are also working under iBank. That is foremost important. So we are not able given to all the community people. So we can able to extend our training program to the person who are working under iBank. So it's a 1 month training program. They have to come and we are giving a theoretical as well as a practical session to them. So that is the one way we can train. So whoever wants, they can apply and they can get it done.
So working under the iBank is like, so they we should be knowing where the eyeballs that they collect will go to, which iBank are they affiliated to, right?
Yes, ma'am. Yes, ma'am.
Or is it a proper? Okay.
They should associate it with one of the iBank. The basic reason is they have to get, as Madam said, so they need a continuous training program. So we have to ensure the quality of retrieval as per our standard operating procedure, and they have to follow everything while they are doing the eyeball retrieval. So we have to be very cautious. They definitely associated with any one of the iBank, and they have to undergo all the continuous training program which was extended by the iBank. And also we have to organize an annual competency review to understand the capability. The three things are mainly needed to ensure the quality tissue retrieval.
So it's a certificate course, sir?
Yes, ma'am. It's a certificate course, 1 month certificate course. We have a limited seat. Whoever wants, they have to apply 3 months before. So we have scrutiny. So we are offering this training program to national and international eyebankers.
So basic qualifications needed for that?
Yes, ma'am. Basically, they have to degree holders with science background.
Okay. Sir, one last question. We'll finish with this. To Sharavanan sir, can you share
Ma'am.
some heartwarming stories of some donor families and recipients whose lives have been impacted by eye donation and transplantation through HCRP?
We see a lot, ma'am, as you all of working in the cornea department. So here, no, we have a case study of 8 years old child who met an accident with her mom. They lost their son in the, so when the incident happened, immediately the child, they lost. So within 30 minutes, his father, they brought a body to the Marcus. And our counselor technician, she properly approached the family members. Within the 30 minutes, the family members said, okay. So it was one of the, highest level of form of concern we ever received from anyone. Within 30 minutes, you just imagine it's an 8-year-old child, right? So the family, even the mother, she was in ICU, but we got a consent from their father and their father-in-law. So they immediately given their consent. It was one of the heart-touching moments for us. So this is likewise, nowadays we received a lot of young tissues at the mortuaries, 14 years, 18 years, 22 years. Likewise, we got a lot of ages. So nowadays, the people know, they really, understand the need of eye donation. They are extending their, they are donating their loved ones' eyes for the betterment of the cornea.
Actually, Dr. Anita, the converse also is true in the sense that we know that the donor and the donation are confidential, but we are the link as the corneal surgeon between the eye bank and the patient. So it is a very good habit to routinely share the feedback with the eye banking professionals about how the hard work that they have put in and the good work that they have done has actually translated into, patient betterment without disclosing the actual details, because no amount of perks or promotions or increments matches, one's satisfaction in knowing that the public social work that they have done has actually translated to vision for a patient. So we as clinicians, I do that quite routinely when they come for eye assessment or, to find out some information or to get some permission that, last week's eyes have gone to a child and, from last month, this patient came back with good vision and thanked us. If we keep telling the eye bank professional both the good and bad aspects of what we face in the clinic, then they have a much better sense of involvement in the whole process, which itself becomes an incentive for them to work better.
Any other views from the panelists?
Sir is there if you want.
Sir, please unmute, sir.
Yeah, good evening. I think it was completely a technical session by the medical practitioners. We play a very low role. We are the NGO, like as you said, the partners in service, probably who helped the Aravind Eye Hospital to establish an eye bank way back through the Rotary International Hatching Grant. I've been going through the sessions probably as a, layman. I have some questions. One is the initiative of an app. It's being widely discussed. My question is why it is being delayed. Is there any technical hitch or a legal terms involved? Because we know for anything and everything today we have an app and anybody can develop. We don't have to wait for get any permission of anyone. But I don't really understand if there is some legal implications with the government. In that case also we can still insist upon. Like very few bigger corporates are in the service of this vision care. So you can very much form a committee or consortium to represent to the government, because if I am correct, for the other major organ transplants, they have already a system in place. You have to be in the queue and it's being done. Why not this? If there is not much of a legal implications, it can be done just like that. Developing and implementing an app is not a big issue. So that's one, my question. Second thing, the MOU, Dr. Saravanan was talking about the MOU with the medical college and hospitals. Why not it is being done, or it can't be done with the private hospitals too? It's only the list was saying about the medical college hospitals, and I'm not sure whether the MOU alone will serve the purpose. In case of a medical college, don't mistake me, because we know the real ground reality. Just by placing an MOU, whether it will serve the purpose, that's one. Second thing, why not it can be done with the private hospitals also, because everyone knows that there is a huge gap between the demand and supply. That's being highlighted from the beginning. I think these are all the major, and probably once the app is in place, whatever the lacunas we are discussing, like, connecting the medical records of a person or anything. See, for example, a scenario, if a death happens, who knows whether this person is blessed or not? Even sometimes his own blood relations may not be aware of it. So if there is a record connected to it, anybody can say, retrieve, and this has been done. So then probably it will be easy to further convince the blood relations, because even if somebody is blessed and if there is an objection, I think we will have to, go with them, if I am correct. So these are all the, and as far as, of course, we, the Rotary community is all along supporting, especially in India, about the vision care. In fact, we have a independent eye hospital completely run by Rotary in Hubli, West Bengal. Likewise, we are ready to extend any sort of support, even in this case of developing an app and implementing. And we have very strong network in India. There are about 45,000 Rotary clubs across. We call it as this SARC region. So if you are of any, can be of any help, yes, we are ready to do it, because developing app is only a technical side of it, that any moment it can be done. Only thing, you people have to tell us whether is there any legal implications as to get approval from the government or any body or something like that, that we are not aware of it. If this can be done, even Rotary will be able to help to develop and implement and spread this message across the country, because the network is spread across in even the rural packets. I mean, not only us, I'm talking about even we can join hands with Lions also. In fact, they give more, attention towards this vision care as their primary project. So these are all a few thought process. It can be addressed, can get some clarity on this.
Oh, great.
Otherwise, it was by both Dr. Saravanan and Dr. Radhika. I think it's a real, may not be able to understand the technicalities, but overall, we could take inputs, like, as a voluntary organization. Probably this will help us when we go and talk to in different platforms. This can throw more light for us, to give a lot of input to the general public. Thank you.
So actually, it's a great question.
Actually, Radhika ma'am had.
Yes, you can go ahead. Yeah.
Sir, no, about that app, madam has already had suggested that it may get misused if some individual people or somebody, if it does it. So it is we have to maybe propose to the government. We have to bring it to them. We have to all join hands, I think, together to do that. It is not one man's effort. It will not be like that. So maybe we will have further meetings regarding this. Like if first we have to approach, I think, the EBAI, and then put up this, and then we have to go ahead with the to the government, I think. For the second question, sir, it is for you.
Sir, thank you for your questions for MOU, signing the MOU, right? So here I have
For the
clearly
private
mentioned
hospitals.
that, for the high and medium hospitals, we are signing the MOU with them because they have a larger mortality rate in the hospital. So for the low mortality hospitals, usually, all the private hospitals, they are having a low mortalities at their hospitals. Whenever the patients know, so about to die, right? Immediately they have to refer to the local nearby higher medical units, right? So the private hospital, they don't have a much deaths. So the other thing, no, we are also covering the low mortality hospital. It means all the private hospitals, whether they are having a high mortality or low mortality, but we are giving 100% coverage to all the hospitals. So this is the base background of this signing the MOU. If it's if the private hospital has much mortality rate, higher mortality rate, definitely we have signed the MOU. For the low mortality hospital, we need not sign the MOU because we have a lot of huge number of low mortality hospitals. So they need not sign the MOU with everyone. Instead of that, we have to initiate the voluntary models. As I suggested, we have to immediately initiate the voluntary model concept to all the low mortality hospitals. So hope I have answered your question. The second, for the professional app, right? So we have submitted and we have discussed this professional iBanking apps 4 years back with various forums. So the main thing is, it's as Madam suggested, it's not a one man show. So it have to be a collective people movement. The another one is, it's a larger agenda. The government should take this this app. I mean, developing app, it's not it's very easy, sir, but managing the app is foremost important. Here, this is foremost important. The government should manage this. So here, still we are, discussing, because as Aravind Eye Care System, we can able to develop the app, but the managing the entire concept, because we have to integrate all the activities related to iBanking under one roof. So it's very difficult. The government should take the initiative. So we have also submitted this concept at various forums. Maybe it may comes, you're well aware of it, right? So it takes some time, but definitely one day it will come true. Hope I answer your question.
That's the right approach of representing strongly to the government and make them to do it, because as you said, but if they decide it's a matter of policy, then it's a matter of time. Like, COVID certificate, just like that, the government developed an app, then the whole population was able to make use of it. It was very useful, flexible.
Yes.
So your execution will not be a problem till we break through, till the point of breakthrough, and make them to understand the necessity and going forward.
Yes. So actually, it's an integration of all the communities, and not only in the community. We have to integrate corneal surgeon. We have to integrate all the eye banks. We have to integrate all the service delivery organization under one roof, sir. It's little bit not a difficult. We have to invest a lot of time to streamline all the stakeholders under one roof. It takes time. Definitely, government will do this, but it takes some time. But definitely, it will come to this.
Right, like this now today, the Mediclaim insurance policies, I think, of similar concept. All the stakeholders are connected, beneficiaries are connected, and it's running on a single group. So must be possible anyway till the time of break.
Definitely.
And second thing, this regarding the private hospitals, as you said, the higher mortality rate, almost, for example, if you take Tamil Nadu alone, every city has got minimum 2 to 3 such big hospitals, if I am correct. So at least in about 30 districts, another 3-4 hospitals means another 100 hospitals MOU can get signed. I mean, that's one thought process.
Yeah, we are working with them.
The limitation is not just the MOU. The donation doesn't happen just with the MOU. You need to have invested and interested grief counselors. Just because an organization signs an MOU with my organization does not mean that every time a death happens, they are going to motivate and, call Shankar Nidralaya to come and receive or retrieve the eyes, because that is not their daily job. Their daily job is to run the hospital and take care of patients. So the more number of MOUs we sign, it could be government, it could be private, it could be any even small clinic. We need to have a proper grief counseling system in place where our counselors routinely attend to these ICUs and keep in touch with what is happening over there, familiarize themselves with the practices, with the personnel, to the extent that when a death happens, the first thing the ICU personnel should think about is my grief counselor. So that is the kind of rapport that needs to be established for these MOUs to yield any result. So the limitation over there is not getting the MOUs signed. The limitation is providing people from my iBank to create familiarity over there to make full use of that particular MOU.
Probably that's a place where this voluntary organization also can play a role.
Exactly. That is a formidable resource. If suppose I have one grief counselor, and if you can provide me with 3 more, then I can sign 10 more MOUs for retrieval of the cornea. The other way around, I can convince my professional colleague and get an MOU signed and get no corneas from there because I don't have a liaison between my hospital and there, because it's not their job to give me a call when a death happens. You know, they will still do it if there is a facilitator.
Yeah, and the MOU, apart from the 2 parties, connect the voluntary organization also as a 3rd party to get in.
That's what I'm saying.
I
So
think
if
people will be ready to help and support if
yes. Thank you so much for the offer of that support. So I think outside the webinar, we can also, link up with you to utilize as much resource as possible, which is most welcome to make the program better.
A question from an attendee, ma'am. Why interstate distribution of corneal tissue is difficult? That is a question.
That is a legislation. So that is a legislatory question. It's not something that you or I can answer, Anita. I think the logic behind that is twofold. One is to enhance the opportunity available for that domiciles patients, and also to put a curb on illegal traffic, illegal practices. So I think that is the mindset behind it, but that is a legislatory question.
Yes, ma'am. Okay. I think we'll close this session. Like, it was a wonderful one. I enjoyed a lot. We have come to the end of this session on iBanking. On behalf of Aravind Hospital, Tirunelveli District Science Center, I extend my heartfelt gratitude to each one of you for joining us today in this insightful webinar on iBanking. It has been an enlightening session, and we are honored to have such esteemed speakers and panelists for sharing their expertise. Especially thanks to SM Kumar sir from DSC and Mutaya Pillai sir for spending their valuable time here. And we would also like to extend our thanks to DTP IT team, Madurai Aravind Hospital, and also to Tirunelveli Telemedicine, and to all the participants who have been patiently listening to receive knowledge and ideas. As we draw this webinar to a close, let us carry forward the insights gained here into our respective endeavors. Thank you all.
Thanks a lot, Anita.
Thank
It was
you.
a very enjoyable session.
Thank you, Anita.
Thank you so much, ma'am.
Thank you, everyone.
Thank you all. Have a great day. Hats
Thank you,
off.
sir.
Thank
Team
you.
Thank you,
Aravind.
sir.